Hello, ladies and gentlemen. Good morning, good afternoon, and good evening to everyone. Welcome to the Cameroon Town Hall for Healthcare Professionals. If you are joining us for the first time, this is a platform that brings together healthcare professionals who are Cameroonians spread across different countries, about 36 countries now. We are about 2,350 members of the town hall. These are people who have attended at least one session of the town hall. So we meet every fortnight, every 2 weeks to discuss on health topics that concerns our country, and we bring in experts each session to present on any topic chosen by the moderators that we think is important and is relevant at the moment. So the moderators do a lot of work to select the topics and to look for the experts. And it's always a pleasure when we bring in experts to speak in the town hall, because we always go in for the best of speakers. Last week, we had Professor Bogoma Titanji, who gave us a very interesting talk on malaria vaccine. And today, we are going to have yet one of us. He's not a first-timer in the town hall. He's always been here with us, and is one who has really contributed to the existence of the town hall. But today, he will be our guest speaker. He's going to be talking on sickle cell disease in Cameroon. Before we get to that, let's just get around with the other moderators. Let me introduce to you some of those who have also been at the very beginning of the Cameroon Town Hall, sacrificed every time to moderate this session. So I'll be introducing the co-moderators. Let me start with Dr. Brian Tegoma. Hello, Dr. Brian. Welcome to this session.
Hi, Elvis. Thanks. It's always a great pleasure, and really thanks a lot for your leadership and your resilience as well throughout since this initiative started. So really greatly applaud the efforts that you've put together. I'm also thrilled for today's discussion on sickle cell. I'm looking forward to hearing Yauba's thoughts and his vision for this ambitious goal for the elimination of sickle cell disease. So I'm really looking forward to his comments. Over to you, Elvis.
Thank you, Brian. And we also have the co-moderator, Dr. Kate. Hello, Dr. Kate.
Hello, Elvis. Hello, everyone in the town hall. Dr. Muno, Dr. Yauba will be presenting today. I had a very difficult day and I was just running, and I said I could not miss this particular presentation. Sickle cell disease, as we know, is a disease that is strongly associated to people who have our skin color, and especially within the continent of Africa. We need to look for ways to, fight this particular disease. So I really look forward to this presentation today. So over to you, Elvis.
And in what part of the world are you now, Kate? It's always difficult to predict.
Come on, I'm not a globetrotter like you, but I'm currently in the UK. So
great.
From the UK.
Thank you very much. It's always a pleasure to have you, Dr. Kate. And Brian also is from Nebraska in the United States, and I am in New Jersey. I know this topic is very close to the heart of Dr. Muno, who is our chair of the Cameroon Town Hall for Healthcare Professionals. Over to you, Dr. Muno.
Well, Elvis, thank you. And I just want to thank our presenter also for last 2 weeks, no one other than Professor Bogoma Titanji, for the wonderful presentation that set the stage. I think Yauba was involved fully in the launching of the malaria vaccine in Cameroon. And just transitioning here, I want to thank him for his time, the short notice for him to share his vision with us, his great public health vision for this disease, which is quite neglected in our country because we don't have a strategic plan really in place in order to fight this. And it's really a disease that has stayed with us for centuries, has evolved with us as we have evolved with malaria. So it's always heartwarming for me to either talk about sickle cell, deal with sickle cell. It's very challenging that I had to move to the US, and when I was in New York, treated more sickle cell patients, gave them better care than I was in Cameroon. So this is out of Africa. The Bronx in New York City had the highest concentration of sickle cell out of Africa, because the highest concentration of sickle cell in the world is in Nigeria. And Cameroon also has a very high burden of the disease. So it's one of the diseases that we need to talk about. Most people don't survive and see their 5th birthday. And we have a lot of infant mortality, childhood mortality, neonatal mortality occurring as a result of this disease, and maternal mortality too, because these women get pregnant. So it's always, I think it's not enough to always keep talking about sickle cell. And I'm looking forward to hearing what our goals could be in order to set up to eliminate this disease and to educate ourselves. And no other person can do it better than Dr. Yauba, which Elvis, you know him very well. And I think you have the honor to introduce him.
I think, thank you very much, Dr. Mono. Yauba needs no much of introduction, but we're going to do our best just to say who he is. We really want to thank you. The town hall session always just take this format. We will hand over to our presenter who is going to take the first hour to do his presentation. And thereafter, we shall have a question and answer session. So once he's presenting, you can keep your questions till the end, and or you can type your questions in the chat also when the time comes. But the format is always to raise your hand when it's a Q&A session, and then we will give you the time. The town hall is a place where everyone is equal and every voice is equal. We all just share knowledge and interact and make sure that we take home just the essential that can bring about change to the public health system in our country. Now we have someone who is not thinking about 2030 like all other political visions, but is thinking about 2060. Who is not just talking about treatment and solving the immediate problem, but is thinking about roadmap to elimination of sickle cell disease. So the topic today is roadmap to sickle cell disease elimination in Cameroon. And he's thinking about strategies, action, and policy priorities. So our presenter today is Dr. Yauba Saidu. He's currently the country director of the Clinton Health Access Initiative in Cameroon. Yauba Saidu studied in the Faculty of Medicine and Biomedical Sciences in Cameroon. He had his master's degree in vaccine development, and also he has a Ph.D. in public health, and he's done a lot of work in research. First, he is really grounded when it comes to clinical research and clinical trials, as well as just program implementation. He's done just a lot in Cameroon. During the COVID-19 pandemic, Yauba was one of the leading voices in trying to see how to improve on the oxygen supply chain in Cameroon, and has done a lot to make sure that many hospitals in Cameroon today have oxygen supply. We're talking about malaria, which is also having a link to sickle cell. Yauba is doing a lot of work in that space, trying to make sure that malaria patients get the best of treatment, but also to really improve on the prevention efforts of the government. Talking about cancer, Yauba is one of those who has really helped the Cameroon government to negotiate prices for anti-cancer medication, and is working very hard to make sure that cancer patients in Cameroon have access to medication. All this through the Clinton Health Access Initiative. So Yauba Saidu is really one of the respectable figures in improving public health strategies in Cameroon. Today, he'll be talking about sickle cell, and without taking much time, I hand over the floor to Dr. Yauba.
Thank you very much, Elvis. I don't know whether you are able to hear me.
Yes, we can hear you, but if it gets better, that will be...
But if it's louder, that will be good, but we can hear you.
Okay, so the challenge here, the challenge we have now is that it's actually raining. So you could be hearing a lot of rain hitting the zinc. So is it better now?
I think it is better.
And can you see my screen?
Yes, but you have to put it on the slide presentation mode. We can...
It is.
Yeah, you can go ahead like that. That's fine.
We are seeing your thoughts, so if you can switch to the presenter's mode.
I actually see the presenter's mode. Okay, what do I do? What do I do? Okay, now I know what to do. Actually have two screens.
Yeah, with two screens, it becomes challenging at times to switch it. So if you can't switch, then we
can you see?
Perfect.
Yes.
Okay, great. So this is the title of the talk. I think Elvis summarized it very well. So it is really my thinking and perhaps hope that it's actually possible to eliminate sickle cell in Cameroon. And the way to do that is essentially closing the tap, managing and cases and also managing cases, preventing complications, and also cure. You will hear from perhaps a bit during this presentation, but those who are interested can always link up to Mona about the advances in care and treatment of sickle cell. So I have this slide that I actually borrowed from Dr. Mona, who, as Elvis mentioned, is not only passionate, but is an expert in sickle cell. So here you could actually see three principal buckets: the pathophysiology, the complications, and the different options that are available for managing patients with sickle cell. And the reason why I put this slide is essentially to ensure that people who are clinically oriented don't get frustrated with this presentation, because it's gonna go off the tangent very soon. So what do we actually know about sickle cell at the in the first place, at least from a biological standpoint? We all know that it's a genetic disease, and that actually represents a mutation at the sick position of the gene where glutamine where glutamine is replaced by valine, and when that happens, then the hemoglobin that is being formed can easily polymerize and then form some sort of an S shape or a sickle shape. And when that happens, then we have a number of things that could happen, like hemolysis, increased cellular adhesion, as well as a decreased nitric oxide, which could actually lead to conditions like anemia at best, and which can be fatal, but can also cause what we call vaso-occlusive crisis or vaso-occlusion, which is a syndrome that presents with a number of things. So it can be acute, it can be chronic, but one characteristics of this vaso-occlusive crisis is usually like pains, but it can also like usually it's like the manifestation, but it can go beyond that to present to cause things like acute chest syndrome, stroke, and even hepatopathy, splenic sequestration, even priapism, infarction at the level of the retina, and so on. And it also has complications in other organs like the lungs, blood pressure, kidneys, liver, eyes, ulcers, and so on. So it's some sort of a multi-organ disease, and that is really what makes management complicated. And in terms of management, I think there are a number of things that could be done, particularly with respect to the presentation at the time that the doctor is seeing the patient in the hospital. But I think there are a number of things that could be done upfront, really to prevent the child with sickle cell to actually go into these complications that will warrant the child to be rushed to the hospital, and that has a lot of cost implications, also a lot of direct medical cost implication, as well as indirect cost implications. So interventions like vaccination, particularly vaccination against some of the germs that can cause deadly septicemia in these children, particularly the encapsulated germs, are really recommended. But unfortunately, children in our settings don't receive them. So this kind of concern things like vaccines, vaccination against pneumococcal pneumonia or meningitis, and so on. But some vaccines are available, particularly those against pneumococcus, but uptake is usually suboptimal. So issues about eye care, which is very important to detect any abnormalities at the level of the retina. So those things are not also systematically done. And I think primarily most of these failures are usually due to our lack of awareness from the part of the clinicians, but also from the part of the parents. So other important aspects like acute pain management of pain is also very important, particularly for those children presenting with vaso-occlusive syndrome. And generally, I think there are a lot of options that people could use to manage pains. But when it gets very severe, I think the options are limited, usually to medications like morphine and so on. But again, accessing morphine in our setting is really, really problematic. We don't have morphine. And I think many of you have family members or relatives who have been suffering from conditions that require advanced pain management. And it's so difficult to lay hands on this medication. So other things like screening. Screening is very important. And this is really the tool that can actually be used to successfully eliminate the disease in Cameroon. It's a genetic disease, which means that if you pick up the people with the threat and then counsel them in short, change their behavior so that they don't get into unions that could actually result into the birth of a sickle cell of a child with the sickle cell disease. That could actually be like a game changer and could be like a phenomenal pathway to elimination. And then there are other conditions like the approaches like disease-modifying agents, hydroxyurea, and so on, and even gene therapies. But those are very expensive and could only be available in countries like the US or other advanced countries or developed countries. So in essence, those of you who are very clinically oriented, I think this can actually serve as a motivation to listen to the things that don't actually make sense, but that the things that actually drive results and change society. So I believe that you'll be like reassured, motivated to continue listening to this talk. So let's go now to the epidemiology. And the interesting thing is that when people who have studied sickle cell, I think a number of things that are clear. It's a very old disease. It's an ancient disease. So it has appeared in the literature in a very long time, maybe almost 600 years ago. And if you look at the literature itself, you see that there are some reports from Ghanaian families in about 1670 and also in Nigeria in about 1870. So most often in Nigeria, sickle cell children have always been branded like Obanje children, and Obanje essentially means the child that goes and comes. So if you have the parent, in short, if you have parents who are like carriers, each time they have like an SS child, the child will die maybe after 1 year or 2 years, and then they put to bed another child. They will say that the child who went, who is back, is gonna go away, and so on. So these things are known in a lot of African societies. And essentially, it's a very big problem, as Mono and Elvis were saying. So each year, over 500,000 children are born with the disease. And currently, we have close to 8 million children. In short, majority of them are actually children who are living with sickle cell. And this is data from 2021. And the sad thing is that 50 to 90% of these children do not actually live to see their fifth birthday. And the probability of them dying by the time they are 5 is very, very high. And they die after they have put their families in short, after their families have undergone through a lot of medical, social, and even financial, and maybe it's societal stress. So it's a concern. It's a really, really big concern. And again, most of these cases of sickle cell as well as deaths that occur in sub-Saharan Africa. And then if you could look at the map, you see we have some cases in the US, not very significant. A little in Alaska, is it in Alaska or somewhere? Some in Latin America, but the majority of cases are kind of concentrated in sub-Saharan Africa, particularly in countries like you could see here, particularly in this belt at least moving from the west coast around Gambia right down to Democratic Republic of Congo. So it's a problem that seems to be localized within sub-Saharan Africa, and because it's a sub-Saharan African problem, the incentive for manufacturers or even developers to develop products or interventions that could control the disease is really lacking. So that is really one of the primary reasons why we don't see a lot of innovation in this innovation in terms of diagnostics and also therapeutics to treat this condition. So the market incentives are essentially not there. But notwithstanding, I think the civil society has a very strong role to play to actually raise awareness so that the different stakeholders could actually invest the necessary resources. But importantly, I think there is actually a growing interest given the fact that sickle cell has been identified as one of the leading causes of child mortality globally, and that has actually triggered a lot of interest from the global health community. I think there was a paper that was published in the Lancet, I think last year or so, that actually ranks sickle cell as I think this is like on the 11th position as one of the leading causes of childhood mortality in the world. But importantly, mortality is high. But if you want to look at other things like disability adjusted life years, or also the burden, the economic burden that is being imposed on families by the condition, the figures are really staggering, and that is really like one of the reasons why we must really do something. So moving forward, I think sickle cell is interesting in the sense that it links medicine to a number of disciplines. One is biochemistry, the other one is pathology, natural selection or evolution, population genetics, and so on. And coming back to natural selection, the important thing to highlight here is that there is really a strong correlation between sickle cell and malaria. So if you look at the map on your left, you see the distribution of countries, the area, the surface area that is that has high malaria transmission. So the burden of malaria is high. And then if you look on your right, you will see that the map that represents that depicts the distribution of children with sickle cell or the allele, the HBS allele, you see some similarity. In short, it actually mirrors the distribution of malaria. And there is really a reason for that, an evolutionary reason for that. So in short, in areas where you have a lot of malaria transmission, you will tend to see like a large number of people having the AS allele, and the simple truth is that, at least from biology, the AS thread is more resistant to malaria, to Plasmodium falciparum, or essential Plasmodium falciparum. And then the SS thread is very susceptible, and most often people, children with SS thread, they will die. They will not live long to survive. So we have evolved in a world where the SS thread has actually like evolved as a survival mechanism against malaria. But I think it will be interesting to actually see whether this is going to change, particularly in areas where malaria has been eliminated, particularly in countries like Brazil, and also maybe some of the Latin American countries, and also Southeast Asian countries, and perhaps Cape Verde, where malaria has been eliminated. So I think it can be of interest for people who are doing like molecular genetics or molecular epidemiology to look at some of these things to see how they're going to evolve with time, given that malaria has been eliminated. So here is actually an important maybe slide, at least for people who are kind of interested in really going into the details of sickle cell. And here we are actually talking about the haplotype. So if you are SS, in short, not all SS are the same. So we have like different haplotypes of SS, and there is one that is really, really deadly, and that is like the Bantu haplotype. So if you have like, do I say, which other haplotypes we have? We have like the Benin haplotype, or maybe the Cameroon. No, actually the Benin haplotype, the Central Africa or Bantu, or even the Saidu haplotype or Senegal haplotype, you are really less likely to suffer from the complications of sickle cell that we just highlighted, like vaso-occlusions and so on, and even die from the disease. But if you have other haplotypes like the Cameroon and the Bantu haplotype, then we are really, in short, we are more likely to have those complications, and you are more likely to succumb to the disease. So the message here is that not all haplotypes are the same. In short, not all haplotypes are the same. There are some that are more deadly than others. So now, before even thinking about elimination in Cameroon, I think it would be nice to like take stock on what is like the state of arts of sickle cell care and management in Cameroon. And we have done a lot of work trying to like study this, particularly through Dex reviews or reviewing the literature, looking at the global burden of disease database, and also looking at all the publications that we could lay hands on sickle cell from Cameroon. And I think we found about 106 publications. Most of them were actually like case series and so on. But at the same time, we also kind of did some sort of interviews with different stakeholders, organized workshop, conducted data analysis to actually see what insight we can derive from the newborn screening programs that have been existing or have been piloted in the country. And I think the next section of the presentation is really going to focus on that. And I think I just have to be rapid. I just have to move fast so we could stay within time. So when we look at the leadership and governance pillar of our healthcare system, I think there are a number of weaknesses, but importantly, we do have a guideline and that outlines how sickle cell disease should be managed. So, but there are a number of concerns, particularly with regards to how well this sickle cell guideline is available at health facilities, and whether healthcare providers are even aware of it and whether they use it. So that's really like a concern. And we do not really have like a department, structurally or functionally, a department that is really in charge of controlling or designing and implementing policies and strategies to control sickle cell. But we have like a tiny unit within the Ministry of Public Health or the Department of Disease Control that is focused on that, but it's really not functional. So we think that to really eliminate sickle cell, we definitely will need to have an integrated primary healthcare system right down at the health center level that could provide the frontline healthcare workers with all the tools that they need, particularly screening during antenatal clinics and also during vaccination clinics, and also things like during premarital counseling and so on. Having such systems in place can actually enable us to pick up maybe the 9 million cases that the 9 million Cameroonians who are estimated to have the sickle cell trait. So this is a couple of the in short the snapshot of the guideline that exists. I think was last updated in 2021, and again a number of questions remain, like what is the level of implementation, how many healthcare workers are aware of its existence, how many use it, and how regular is it updated. So I think the guideline is good. So it actually shows that the Ministry of Public Health, it should actually demonstrate political will because this guideline is developed by a group of experts and then endorsed by the minister. So it's actually like a plus having this guideline. So in terms of screening, I think we have just few centers, few single center and maybe multiple center newborn screening pilots that have been conducted. But really, screening is really is to a large extent inexistent in many health facilities, many primary healthcare facilities, and even in big hospitals. So children are not systematically screened for sickle cell for sickle cell threat in our facilities. And we have had one pilot, very large pilot, that screened over 60,000 new neonates between 2015 and 2016. And again, 60,000 is just like a tiny fraction of the number of infants that are born in Cameroon. So I think we all know that each year Cameroon registers about 1,100,000 newborns, and then we have almost about 940 or 940,000 or 950,000 surviving infants. But most of those infants, they are not screened for sickle cell. And then if we are in a state where screening for sickle cell threat during antenatal consultations is also suboptimal, then it becomes very logical to think that we are missing a lot of cases that we could pick up. And I think I saw one report that when a child is born, a child with sickle cell, so the median time for diagnosing the child with sickle cell is about 4 years. So you leave the family, in short, those weaknesses will cause the family to, the families and also the child to go through cycles of pains and suffering for about 4 years before the diagnosis is established, which I think in this day and age is really unacceptable. Again, the National Reference Laboratory offers discounted screening for children below 15 years. And this is good, but again, the question is the reach. The National Reference Laboratory is located in Yaoundé. How do you get children who are perhaps in Marwa, from Bamenda, or maybe Ebola and even other areas to be screened? So making this thing work, I think you would definitely need another system, particularly sample transport system where you collect the sample and then you get into the complexities of establishing a sample transport system or network. But again, that will also be dependent on the availability of healthcare workers who are trained and who are also capable of suspecting sickle cell in the child. So again, there is a limitation or there is a weakness in that area which should be corrected. And then more importantly, this premarital screening, which should be recommended by counselors and also religious as well as traditional authorities. I think this is really what is an opportunity that is being missed. So if we really want to detect or even prevent couple of people with sickle cell threat going into union, this is really where we need to anchor. And again, there are opportunities, as you will see. So we think that to actually eliminate sickle cell, these are the things that we need to do. Have a robust national newborn screening program, and if we are not able to screen children at the birth to actually establish whether they have the disease or they have the threat, then we could catch up maybe in schools, which actually reinforces the need of having very strong school health programs. And this can really be enforced, ensuring that children do know their sickle cell, their sickle cell threat, as well as their blood groups and so on before they are even enrolled into nursery school or even primary school or even secondary school. And also reinforcing this concept of screening within religious and traditional institutions. So we can do that. That requires a lot of advocacy, sensitization, demand creation, and so on. But we also need to have the public health infrastructure So it needs to be decentralized, not having only one laboratory at central level that is able to do the screening and so on. So they need to decentralize that and have the necessary inputs to be able to do robust screening at the primary healthcare level will be absolutely critical. And the good news is that we have quite a lot of innovations. I think, Elvis, you are aware of a test that was recently approved and is available in the market. It's it's cheap and very effective. And this test, if introduced into the public system of Cameroon and other countries, it could actually be a game changer because it produces results, at least it produces results within 5 minutes. So this test can actually be like a very big game changer. And it also like connects well to point of care testing. I think that test itself is really like a very good point of care testing. So it can be used everywhere in rural areas, even in palaces or mosques and so on. All you just need is just a blood prick. And then currently screening is expensive. So to screen for sickle cell, parents will need to spend about 7 to 20,000, depending on where you find yourself. But it may sound like small, but believe me, in several regions in the country, families cannot afford 7,000 francs to pay for screening, and that is really why innovations like the point of care case that will cost maybe around maybe $2 or $3 or so can actually be a game changer. So it could address this financial barrier. So here is just like a little bit complex, but just to show you like the flow, the workflow for screening that exists in areas where screening is being implemented. And you could see it's a little bit cumbersome. It could work at tertiary health, at tertiary level, where you have a lot of resources. But if we are thinking of massive screening, public health or community health kind of approach, then we need to think about how to really simplify these things. And in my opinion, I think really collaborating with religious leaders, traditional leaders, and establishing some sort of a community awareness and sensitization program where you deploy community healthcare workers, not only deploy community healthcare workers, get like the traditional rulers during their council of elders to talk about this, and then get them go to the community, educate their families or their neighborhoods, and then request them to come to the palace or to go to the health center to get tested. Those type of approaches could actually like yield significant gains. So we really need to figure out how to demystify all of these complex concepts that require a lot of documentation, a lot of human resources, and that will also create long waiting times for families, and that could demotivate people from also like soliciting healthcare. We need to demystify these things, simplify them, and make the activities to be owned by the community through their leaders and also the family. So if we do such things, we will be surprised by the level of uptake. These are the people who will adhere to these simple procedures. So simplifying all of these things and rolling them out could actually like drive significant improvement and gains. So we look at things like the comprehensive healthcare management, and here we see where we are, and more importantly, we have to note that we just have a few dedicated sickle cell units in tertiary health facilities. Because they are present in tertiary health facilities, accessibility is limited, and most often they are concentrated in urban areas. And what we tend to see now is that the burden or the prevalence of malaria is really becoming lesser and lesser in urban areas. So it's really more of it's really more concentrated in rural areas. So the fact that most of these dedicated sickle cell units are located in urban areas in tertiary health facilities is also a big impediment to access. to access. So we need to figure out a way of actually like decentralizing this. And when we decentralize this, then we need to like figure out how we could actually integrate sickle cell care and treatment into primary healthcare interventions that should be delivered at the first point of contact. That's either at the level of the health center or at the level of the integrated health center or the district. But ideally, at the level of a health center or the integrated health center. So that is that can actually like drive transformational changes. And then other areas of weakness that we so other areas that have received very limited attention is the psychosocial support that is supposed to be provided to the families and also the kids who are suffering from this. It's essentially non-existent. I think I used to like head the sickle cell unit at Fondation Chantabia when I was still doing clinical practice, and believe me, we did not even know or even have the skills on how to like support these parents or families psychologically and emotionally. So that gap actually highlights the need of establishing like protocols or guidelines or a curriculum that healthcare workers can use at the primary healthcare level to actually like educate or provide psychosocial support to parents who are suffering from these conditions. So that needs to be done. And for that to be done, we need to like look at the policy framework. What policy do we need to put in place? And how do we translate that policy into a strategy? And how do we implement that? And how do we get that reach the health facility that is in contact with the population, as well as the community, the traditional leaders, religious leaders, and so on, because these people, they also need to be integrated. And it's so important, particularly when it comes to dispelling myths and also addressing psychological trauma from stigmatizations that families with sickle cell face. So in some areas, it may be stigmatization like Obanje and so on, but in other areas, it can actually victimizing people, like accusing them of witchcraft. I'm beautiful, I have a beautiful kid, you have used witchcraft to kill my kids, and so things like that. So those type of things will kind of require carefully designed programs, educational programs that actually hinge on the psychology of both the families and also the societies. So psychosocial support is really, really important and will really need to be integrated into sickle cell care and management. So moving next, we talked about human resource for health, and believe me, it's a very, very big problem. So a study was done, I think, sometime in short before 2020, where they talked to about 200 physicians in Cameroon, and shockingly, majority of physicians did not have adequate knowledge on sickle cell. In short, the statistics is really, really appalling. So just about 1 in 6 or 14% had the knowledge that people could think. In short, that the assessors or researchers believed that was adequate. And I'm sure that Mono, knowing what you know now, because at least you knew about a little bit about sickle cell when you were in Cameroon, and now you are in the US, where you actually like learn and become like a leader. So if you judge, if you can conduct this sort of evaluation now, believe me, it's the numbers, the numbers are gonna come down. And this essentially is due to the fact that clinicians, be it doctors, nurses, and so on, they don't receive the necessary training in school. Most of them don't get don't undergo pre-service training on sickle cell. So they only learn to do that, particularly in hospital settings. And if you don't have the chance to go to a hospital with a sickle cell, with a unit that is dedicated to sickle cell, then it becomes very difficult for you to even actually know how to diagnose a disease or how to manage the disease. So there is a big knowledge gap, and that will need to be addressed through a number of interventions, like not only the clinical part, but also skills with regards to counseling, with regards to clinic, with regards to diagnosis and treatment, and even follow-up, So we think that there is that need of setting up a comprehensive multidisciplinary initiative to build the capacity of a diverse cadre of workers who could actually like focus on all the different components of sickle cell counseling, particularly in short, all the different touch points where you could make an impact, premarital counseling and education, antenatal counseling, antenatal care, newborn care, and also vaccination. And even when the children are grown up and right up to adolescent care. So we need some sort of a comprehensive and holistic curriculum that could address these type of things, that could provide not only clinicians or healthcare professionals, but the different kind of healthcare workers, as well as those who are not even in the healthcare sectors, like teachers and so on, so they can effectively transmit the message, educate the children or the families and the patients. And again, there is really that need of expanding the number of specialists, particularly hematologists, pediatricians, and as well as doctors who are trained in sickle cell to cater for thousands of children suffering from sickle cell. I didn't mention this, but in Cameroon, each year we have about 7,000 children who are born with the disease. So this is a lot. But if you want to look at the number of hematologists that we have, and the number of maybe pediatricians that we have, and even pediatricians who even master sickle cell, I think the numbers are quite low. So there's really that need of expanding on the quantity and also of the quality of the different cadre of healthcare staff who could now take care of this condition. So moving forward, we talk about information system, and really there is really a big gap here. So we do not have indicators in the district health information system, which is like the National Health Information Management System, that could capture information about sickle cell, and even the conditions that actually led to the death of a child with sickle cell. Is it anemia? Is it stroke? Is it I don't know, vaso-occlusion, or even malaria also. So we don't have those systems that could capture that data. And I think it's essentially important from a decision perspective to be able to know what are the key drivers of death among sickle cell children, or even the key drivers of failure to key drivers of healthcare workers not screening for sickle cell trait during ANC clinic, or not screening children during immediately after birth or during vaccination, clinics. So all of those things are kind of important. If we don't have the data points, then it will be very difficult to actually plan, to actually take evidence-based decisions. And I think in our context, it's important to actually have those data points, because it could allow you to be more precise. And when you are more precise, you know the type of resources that you could deploy with a lot of precision and certainty. So you will not use like the blanket approach where will require a lot of human resources and also a lot of financial resources and managerial capacity and so on. So we think that there is that need of setting up a data system, and that should begin by defining the different indicators that we think will be useful for the government or the Ministry of Public Health to have, and then have these indicators integrated into the district health information system, and then train healthcare workers on how to use these indicators and how to report different variables with regards to sickle cell. When was the child admitted? Is it a male or a female? Did the child have like maybe asplenia or or infection and so on? So those type of data points can actually help the government to take evidence-based decisions, particularly when it comes to management or developing guidelines. And again, just to say that the different guidelines that were developed, I think to an extent they were really like a copy and paste. And since they're copy and paste, they may really not be contextual. They may not serve the purpose, or they may not be. They may not say. They may not be like the right or the necessary tools that could actually inform the healthcare workers, or could actually guide the healthcare workers on which actions to take, right? And most often they have, since they are not based on evidence or on data that is that has been generated in our context, they are broad. So they are broad, lengthy, and perhaps difficult to read. Difficult to read and consult by healthcare workers. So there is that need of really setting up that data system, starting with that, and then capturing different elements, and subsequently using those data points to make decisions to shape policy. So health financing is another challenge, and believe me, countless families in Cameroon, it's actually a constant struggle to afford routine care for sickle cell. So many don't get vaccines, particularly those vaccines that are not provided by the expanded program on immunization. They don't get booster vaccine. They don't get booster vaccines. They don't get additional recommended vaccines and so on. And I think I have a slide that talks about that. And again, most of the spending is actually out of pocket. Families would have to pay. And believe me, if you have a sickle cell child, or if you know of a family that has a sickle cell child, they will tell you that in short, the child has been like the source of expenditure for the family, and this can actually become catastrophic. It can drive the family into hardship and into poverty. And shockingly, there is just no system, financial mechanism in place to be able to support these families. And one of our hopes is really that care and treatment of sickle cell should be integrated into the universal health coverage. So I think Cameroon recently rolled out the first phase of universal health coverage. I think a number of conditions have been included, like malaria, tuberculosis, HIV, and also maternal health, particularly deliveries and so on, and even ANCs. But I think it would be good to actually integrate screening for sickle cell into that package budget, have the necessary resources, and then necessary resources at scale to be able to do these things. And then also provisions for care and treatment for sickle cell patients. And then we think that there's also like that need of putting in place a system that could measure state contribution towards sickle cell over time, because what we tend to see is that if we advocate hard, get the civil society, the state can create a budget line. But then if we slow down a little, the funds may not be disbursed, they may not be mobilized on time, or if they're mobilized, they may not be disbursed. And it's not uncommon to see some sort of a skip pattern. Funds are allocated this year, they are not allocated next year, they are not allocated the following year, and so on. So that's why we think that if we succeed to get the state to create like a budget line for sickle cell, get that integrated into universal health coverage, we need to put in place a system that could measure the contribution over time. We have seen that for the health budget. I think for the health budget, there is a system to track. In short, it's easy to track because those figures are available. But what we tend to see is that we have seen a decrease from maybe about 6% of the national budget to about 5%. And the target is really clear, 15%. So we need that sort of metrics to be able to measure state contribution for sickle cell. And then the medical products, vaccines, and so on. I talked about a study that was done that indicated that 82% of children with sickle cell who were surveyed did not receive the recommended prophylactic vaccine, particularly pneumococcal vaccine and also meningococcal vaccine. And really, no such assessment has been done for other commodities like blood, morphine, or even the principal drug that is used to that is used for the management of sickle cell, hydroxyurea. So it's a really big problem, and really our hope is to see our hope is to have a future where all sickle cell children receive the recommended prophylactic vaccines. These vaccines are available in the private sector. We need to put in place a mechanism that will ensure that these children get these vaccines, even in faraway areas, rural areas, remote areas, and so on. And this is particularly important from the perspective of leaving no one behind, which is an overriding theme of the Sustainable Development Goals, but also from a health, justice, and equity perspective. So children should not suffer because of the accident of their birth. When we public health professionals, we have like the means of making certain things happen, making vaccines reach them. So there is that need. So the second thing is really to ensure continuous availability of hydroxyurea and morphine. So these are like the two principal medications that are actually necessary for managing sickle cell children. So hydroxyurea is good. I can actually prevent children with sickle cell from progressing to complications. So we have excellent stories from Ghana, where massive deployment of this product has actually changed the course of life for many families. And then we also need to have morphine in country that could be used to manage children who are suffering from vacuosis crisis. And then blood transfusion services will need to be readily available, not only for sickle cell patients, but for the broader population as well, postpartum hemorrhage, malaria, severe malaria, anemia, and so on. So I think these are some of the things that we think should be put in place to be put in place, and that should be readily available and also affordable to the family. So if these things are in place, then we are sure that children with sickle cell can actually live a healthy, productive life, and they can actually go up to about 70 years, 80 years, and so on, if all of these things are available. And then community awareness is kind of important, but very limited interventions have been done in that area. There are a number of bodies that are kind of advocating, like Convergence Drepanocytosis, which is a local organization advocating for the rights of sickle cell patients. But again, the gaps still remain. So I think a study was done in one rural health district in Cameroon to assess information, in short, level of information among healthcare providers and also families and university students and so on. So you could see, I think over 4,000 people were assessed, no, over 400, but sorry, students. It's like just the section talking about the evaluation in universities. About 400 plus students were assessed, and just about 1 in 5 had then information or knowledge that the researchers judged to be adequate for sickle cell. And again, surprisingly, just about 1 in 7 actually knew their hemoglobin genotype, which is actually like a very big problem. So if you have like a university where like 6 in 7, like in short, 6 in 7 should be maybe more than 90% do not know their hemoglobin genotype, and we are talking about elimination. So it's very likely that most of them will end up in unions, particular in unions that are likely to lead to offsprings with the sickle cell with SS, particularly if they are AS. So this sort of weaknesses actually highlight the need of really putting in place a civil society and a government that is empowered, a civil society that's empowered and that should actually push the population to actually develop adequate knowledge when it comes to sickle cell, but more importantly, to actually know their hemoglobin genotype. Are they AS? Are they AA? This is very, very important. And this can actually help them to make informed choices on the partners they will want to have. And this sort of the civil society empowerment should actually happen in basically all levels in rural areas as well as urban areas within the Christian faith as well as the Muslim faith, as well as people who do not even believe in God and so on, in offices, in short, in all sectors of life. So it's absolutely important that we put in place a system or a mechanism that will enable people to actually know their hemoglobin genotype. And we need to figure out really how to empower the civil societies or the authorities that are concerned to be able to transmit this message. Because this is really like the starting point. So if you could do this, if people could know their hemoglobin genotype, then we are effective, and then follow the counseling of medical professionals as well as clergies, then we are very sure that we can close the tap. We can reduce the number of sickle cell children who are being born annually, maybe from 7,000 to 5,000 or 2,000, and eventually lead to a complete elimination of the trend within the population. So again, this is high level, but these are some of the the slide is busy, but these are really some of the opportunities that we see. WHO Afro has a sickle cell strategy, but that strategy needs to be translated into national strategy, regional strategy, and then work plan and so on. And for Cameroon is currently developing a non-communicable disease strategy, which is being finalized. But we still think that there is really that need of having a strategy that is really specific for sickle cell, just like what we have done with hepatitis C, a strategy to eliminate hepatitis C by 2030. I think Rwanda is almost there because they had that strategy. So I think those type of laser focused strategies are kind of necessary. And then we think there is really that opportunity because a lot of schools do have school health clubs, particularly secondary schools, but we think there is that need of really strengthening health promotion in schools, beginning from nursery schools, daycare, nursery schools, primary schools, and also secondary schools. And there are a number of interventions that could be done, particularly screening and counseling. Particularly in nursery schools and primary schools. And if we do that, put those type of systems in place, then we are sure that we can pick up, we can effectively establish a diagnosis of sickle cell trait before the child is reaching his or her fifth birthday. As I said earlier, I think there is a study that indicated that the median time for establishing a diagnosis is when the child is 4 years old. And by that time, we have had a lot of damages in the system from vascular occlusion and the effect of sickling on other organs. So if we have a system in place that could pick up those children early on, then we have the necessary input like hydroxyurea and so on. Then doctors are trained to effectively administer the medication. Then we can prevent suffering from suffering of the children as well as their families. But more importantly, in secondary schools, if we have a screening system, then we can advise children on who to go into a union with and so on. So that level of awareness can actually help students to make an informed decision with regards to their partners. absolute necessity of integrating newborn screening into other programs, other established programs like antenatal care, routine immunization, HIV care, and so on. Absolute necessity of engaging religious organizations as well as municipalities, encouraging them on the need for premarital screening before signing before signing a marriage certificate or so. Those type of interventions can actually help to reduce in short, the number of sickle cell children that are entering into the population. I know at the start, it can be painful to lovers to tell them that, see, you cannot get married. But believe me, from experience, what we see is that when couples have a sickle cell child, most often they end up in divorce, and the woman actually bear the greatest consequence, the greatest burden. The man will run away, allow the woman will live in torture, in sufferings, and so on, and can also have an impact on her mental health. So I think using those type of lessons, framing the story, can actually help, particularly girls who actually hold like a very strong bargaining power to make informed decisions about their future partners. Then we need that we think there is that need of establishing sickle cell clinics in primary at the level of primary health centers, in mission hospitals, particularly in areas that are not traditionally reached by the government, and we need to figure out how to better support those mission hospitals to deliver on those programs. And then at a global level, I think there is this Lancet Commission on sickle cell that was created, which could really act as a very strong voice. And in short, they have been acting as a strong voice. They have been able to convince, I think, open philanthropy to put aside some money that could fund sickle cell control programs in sub-Saharan Africa, and also in the United States and other countries. And then local and international NGOs, they will have a role to play. They will definitely need to integrate this in their strategies and in their operations, and also make it a some sort of a cross-cutting interventions in their different programs. You have a malaria program. You are an organization working on malaria. You need to actually integrate care and treatment for sickle cell patients, because they also suffer from malaria, and there is a link between malaria and sickle cell. So there is that need of actually working with global health actors and professionals to shape the way that they design their programs, and then ensuring that they intentionally include sickle cell, careful sickle cell within their different programs. And then financing, there is a need for funding, and so on. And then at the level of child, we have like one unique maybe opportunity to be able to shape the market, particularly for hydroxyurea. And one of the reasons why hydroxyurea is not readily available is because the manufacturers think that there isn't a sufficient market, right? Which is not true. So if you look at the number of children who are born, we said about 500,000 children, and they will have to take a capsule of hydroxyurea on a daily basis for the rest of their life. And then we have a number of children entering into the pipe annually. So if you're able to demonstrate that volume guarantee, then the manufacturers will have that incentive of actually producing that product, and even reducing the cost or selling it at factory prices, which could be readily available, affordable by the government and also families. So let me just move forward, and here is just the core things. We do not really need significant resources to start, so we just need to figure out how we can integrate sickle cell care and treatment into existing programs, like community healthcare programs, which is being funded by Global Fund and a number of organizations, World Bank and so on. So how do we get the community healthcare workers to actually advocate for screening for sickle cell trait during ANCs, or like educating religious leaders or church leaders on the need to reinforce premarital counseling and screening and so on. Oxygen is available now in many facilities. How do you use that to treat sickle cell patients? How do sickle cell patients benefit from those investments? Should they pay the same rate as others, and so on? Vaccine delivery. There are vaccines that are already available within the expanded program on immunization. Can children with sickle cell get the vaccines? Yes, they need additional vaccines. What can they do to get the additional vaccines? And can vaccination touch points be used to screen for sickle cell trait? To screen for sickle cell trait. So when they come for 6 weeks, can they do like a simple test using the rapid diagnostic test kit to establish whether they have the sickle cell trait, and so on? And then life course vaccination. And I think this is really one of the areas that could actually help. So if we succeed to actually build a life course vaccination program, particularly for Cameroon and in other areas across sub-Saharan Africa, then we are sure that we are setting up the platform that could enable children with sickle cell to get the additional vaccines that they need, right? So if you take the context of Cameroon, we have the expanded program of vaccination, of immunization that provides vaccines at 6 weeks, 10 weeks, 14 weeks, 9 months, and 15 months. And that is all. So after 15 months, children don't come back to the hospital. But I think at about 24 months, maybe 5 years, 6 years, 9 years or so, those children will need to get vaccines, particularly booster dose for DPT3, booster dose for diphtheria, tetanus, and pertussis, and perhaps hepatitis, and so on. But they'll also need to get polysaccharide vaccines against encapsulated bacteria, and so on and so forth. So that building that life course vaccination platform can actually have these children benefit from these conditions, from these interventions. And then the area of cancer, particularly working with the government to actually improve on the availability of the 2 key molecules that sickle cell patients will need, particularly hydroxyurea as well as morphine. So we are doing that for other molecules, and it's taking shape. And then I think it would be nice to like incorporate hydroxyurea so that this product can be available in the different centers that provide treatment for sickle cell. And then HIV again, HIV, and more importantly, antenatal testing. So you need to we need to ensure that mothers are screened for they need to know their hemoglobin genotype when they come for ANC, right? So at ANC, they essentially test for blood group. That is the minimum package, but they don't go further to do like electrophoresis to actually understand the hemoglobin genotype. So we really need to reinforce this stuff. And then civil society, we have spoken about that and so on. So let me just move forward. I think here a piece of work that we are doing. We have established like sentinel sites, mostly integrated health centers, where we really want to like build the capacity of the health facilities to actually serve as model sites for the management of diagnosis and management of malaria and other things like entomology, efficacy studies, insecticide resistance, and so on. So it's actually an opportunity to integrate sickle cell in this program that is already existing. It doesn't cost anything. The resources are available, the systems are available. It's just maybe integrating, maybe just making a recommendation that in addition to those things, screen for sickle cell, ensure that hydroxyurea is available, and things like that. And then the same is also true for other programs like elimination of congenital syphilis. I think we have an organization that is already working on that, and I think we have partnered with them to kind of ensure that they roll out their program as well in this sentinel sites that are representative and that are kind of dispersed all in short across the country. So we don't need much resources, but again, I think leveraging on the low-hanging fruits can enable us start building the database or generating the data that we will use for advocacy to demonstrate that this is possible, it can be done, it should be done, and it's actually the right thing to do. And then last but not the least, before I end, I think I just want to reemphasize that to really get this thing done, there is that need for partnership. And this is clearly outlined in the Sustainable Development Goal number 17. We need partnership for result. And in the context of sickle cell, I think we need diverse, we need the contribution of several stakeholders. Farmers who produce the drugs and the diagnostic kits, government through policies, strategy, financing, global health organization, through advocacy and funding mobilization. Development banks would also need to play a role. And for us to get development banks to play a role, we need to demonstrate to them that there is a moral and also an economic obligation to address sickle cell. It can be eliminated, and if it's eliminated, we are sure of having thriving families and societies. Bilateral organizations, civil society organizations like the diaspora and including the diaspora. So you guys in the diaspora, you are part of the civil society. So you also, and this is really like one of your own contribution, bringing people together, bringing people to talk about a subject, using that to like formulate recommendations and so on. So we really thank you for that. And also like having the recordings on YouTube or on Facebook and so on is incredible. It's helping to disseminate the message. So perhaps one of the things we could do next is really to figure out how to make some of these presentations less technical and figure out a way of sending them to platforms like TikTok, making them like 5-minute videos, educational in simple terms that communities could actually use, right? That could be disseminated through WhatsApp, to different families, communities, and so on. So if you could think about that, I think that is going to help a great deal. So how do you like translate this concept and these technical things into things that could be easily understood by lay people, religious people, traditional rulers, and even people who do not speak English. So I just want to say that during the just an example out of the box, Professor Titanji actually did a video on malaria, and he's talking about the malaria vaccine and why parents should get their children vaccinated. The vaccine is safe and so on. And she did this in pidgin, in a layman's language. And believe me, you would not imagine the number of people who saw that video. You will not imagine. So interventions like that can really have a significant impact. It can have a significant impact, translating complex concepts into simple ones that could be understood by the community. I think things like that could have a profound impact. And I would really want to appeal to Mono and Elvis to really think about this seriously. How do we translate complex concepts that we present in the town hall into information that could be available on TikTok and that could be useful and shared to communities in English and also in French. I think those things can actually bring profound change within communities. So again, I want to say that we are we are really passionate, and one of the things that is making me have this big dream of eliminating sickle cell by 2060 is because I have like some people who are really passionate about sickle cell, and everything that is driven by passion, we are very certain that it can happen, right? So we have Mono, who is very passionate about sickle cell. We have Dr. Makia, Christine, who is also very passionate about sickle cell. And then we have Francois, who decided at least to leave clinical practice and then create an organization, the civil society organization, is it FAHADEF, that is essentially focused on sickle cell. So you could see how someone would just get up and say, no, this is what I want to do in my life. I want to create a civil society organization, and I want to focus on sickle cell, nothing else, without even thinking about how am I going to sustain this organization. There is money in malaria, there's money in HIV and so on, but she doesn't care about those things. She cares about sickle cell. And the same is true for Michael. So Michael actually works for me. And when I was doing like this type of scoping, literature review, and so on, I was, in short, I was struggling alone, but I didn't actually know that I have somebody in-house who is passionate. And when I brought the topic to him, in short, I wanted to give him another role. He said, no, he's not interested. All he's interested in is sickle cell. So you could see already within the space of 2 months, is it like, no, just 1 month or so, you could see like 4 people with a burning passion to address the burden of sickle cell in Cameroon emerge. And I believe that after this presentation, the list is going to expand. So this is really my hope. This is what keeps me impatiently optimistic, as Bill Gates would say. These 4 people, I think they have the potential of actually sending sickle cell to the museum by 2020. By 2060, if they keep on with their drive, we're gonna support them with what we know what to do, like making things work, transforming plans into actions and so on. But we need your passion, we need your drive, and we want your passion to be contagious, contaminate other people, so that they can get into this fight. So already we are making we are already generating data. I think we have a couple of publications that we're going to publish, 3 of them, manuscripts and so on. And I think this is in line with the advocacy, building the case. So this presentation, we have translated this presentation into a publication, into a manuscript, which we are going to submit to a journal for publishing. So anyone who wants to know anything about sickle cell, the state of sickle cell care and treatment in Cameroon, can go to the publication and read it. But more importantly, we're going to prepare a paper on call to action. What can be done to eliminate sickle cell in Cameroon by 2060? And most of the content will come from this presentation and also the comments and suggestions that we'll give. So I don't know whether Michael is on the line, who will be, and I don't know whether he's on the line and whether he will be able to take note. But if he is not, I'm also very confident in Elvis's ability to take the note better than the presenter himself. So this is how we want to do. This is our theory of change with the different with the different activities, the outputs, the outcomes, and so on. And if we implement this, we can essentially reduce suffering or death from sickle cell, which is good. But we are going to develop another one on really what the concrete things that we should do to actually stop, to actually eliminate the number of children, the number of children trickling into the into the basin, at least through premarital screening and counseling. Again, there are opportunities. We do have like the network, and we do have a number of religious leaders who are also very passionate. So you could see them on this picture. I don't know, it's a cross section of in short, basically all the religious leaders in Cameroon that I brought together to talk about malaria vaccine. So the contacts are available. We can always engage them, go back to them, talk about sickle cell, and so on and so forth. And the good thing is that one of the things that I do now is really to write sermons for religious leaders, be it priests or Protestant pastors or Muslim clerics, and so on, to inform so that they can read it to their faithfuls during Friday sermons and also during Sunday sermons. So you could see some of the things that I learned in St. Augustine. So I'm actually beginning to put them into use in the name of the Father, the Son, and the Holy Spirit. So this type of things can actually help, right? Help build a connection between you and maybe the religious authority. You don't only come and tell him that, see, this is sickle cell. It's the problem is that is it like position 6 where valine has replaced glutamine and so on. He's not going to understand those things. But if you tell him that in the name of the Father, the Son, and the Holy Spirit, peace be upon you, and so on. If you have a sickle cell patient, the faithfuls will not be able to bring them to church. So the child will not be able to go to doctrine and learn about the ethics of the doctrine of their religion, and become like a faithful and so on. He will not understand you. But if you present the story in that way, he's gonna understand you, and he's gonna become like a real champion. Why children, sickle cell children, should be healthy, so that they go to Sunday school, they learn the doctrine of their religion, the mystery of the Rosary or the Trinity, and so on and so forth. So I have learned all of those things, particularly thanks to the malaria vaccine, and I think these are learnings that could actually like help to drive this sort of interventions that will involve a large range of stakeholders, including religious and traditional stakeholders. So perhaps one of the things I need to learn is how traditions happen. And Elvis, I know you are notable in so many Gumba houses, but I doubt whether you know you know how to drink palm wine from a cup. So again, I just want to like end here with this slide, and then just actually show like the 3 key points, what can be done and where it should be done to eliminate sickle cell, or you should eliminate it, and to the point that it will only be found in medical literature and museums. So this is point number 1. This is point number 1, and it actually it's the replacement, it should the sickle cell threat. So I call it closing the tap, preventing 7,000 Cameroonians from being born with sickle cell disease. And this is where interventions like premarital counseling, engaging the civil society, traditional authorities, as well as religious authorities, municipal authorities, before signing a marriage certificate, they need to ascertain that these people have done hemoglobin electrophoresis. The couples know their hemoglobin genotype. And this needs to really start at the level of secondary schools and even primary and even nursery schools. So we need to figure out where it needs to start and where efforts need to be intensified, where we're gonna put like some control points or toll gates or checkpoints and so on to ensure that those things are being done. And believe me, if we do that, we're gonna see informed decisions when it comes to choosing, making like marital decisions or even having children. So that can help. And then secondly, if we happen to like miss those in short those touch points, and then we have the child with sickle cell, we will know exactly what to do, right? We will know we have the vaccines to give the child. We'll provide eye care. We will ensure they get the appropriate nutrition. will control the blood pressure and so on. And in the case they develop maybe complications, we have the medication. We know the medications to provide to them. But if we close the tap, then we have fewer cases to manage, and the resources that will be needed will be less. The health expenses from the family and the government will be less, and productivity is going to increase. And again, if we are able to do that, just simply using like disease-modified agents like hydroxyureas and all of those things, we are sure of really getting those children to live up to about 50, 60, 70 years. So they can actually live a healthy, productive, and fulfilling life. And now, if we get richer, then we can think about curative therapies like stem cell transplant and even gene therapy. But these things are very, very expensive. And what we know is that innovations like this, before they reach the developing world, will need a period of about 20 years, right? But if we implement these primary healthcare approaches, by the time it's 20 years, we have like significantly reduced the number of the children with sickle cell, and then we have like a fewer, in short, a fewer number to actually manage. So this is really how I see things. We will definitely need to close the tap, and then so as to prevent children. We close the tap to prevent children with the threat to enter the population, and the ones that enter will need to like prevent them from dying from the disease through those interventions. And lastly, we figure out how to really get some advanced therapy in Cameroon. That I'm not really hopeful. I know it's going to be very expensive and so on, but I think we need to like redesign our focus. Let's focus on really closing the gap and also management. So I think this is what I had. I have taken like 94 minutes, 1 hour, 30 minutes. And my excuses if I went beyond the time, and I'll be happy to take questions. I see almost about 34 people, 34 messages in the chat. So I thank you all for your kind attention. And of course, I'm not a sickle cell expert. Direct the simple questions to me and the difficult questions to Mono and Elvis.
Thank you very much, Dr. Yauba Saidu. Quite really an impressive presentation. You kept us really attentive for 1 hour, 30 minutes. Very few presenters have done this in the past, with an average, presence of about 50 to 55% constantly listening to you. It's really amazing to hear Yauba speak and really keep us attentive. Yauba is a Muslim, but he will articulate very well and quote verses in the Bible. These are the kind of free-minded people we need in our society, who can cross all barriers when it comes to doing good and helping people. Thank you very much for this excellent presentation. Ladies and gentlemen, if you are joining this for the first time, this is a Cameroon Town Hall for Healthcare Professionals. We meet every 2 weeks, Saturday at 1 p.m. Eastern Time, or right now 7 p.m. Cameroon time. And we always choose a presenter that comes to talk on a very important healthcare topic that affects the life of our people in Cameroon. We are spread across different parts of the world, and we all encourage each and everyone that as we enter the question and answer session, if you want to ask a question, just say where you are asking your question from so we know our reach for today. Thank you very much, Dr. Yauba. While we give you some time to get a sip of a glass of water, let me just go around with the moderators before I hand it over to Dr. Kate for the Q&A session. But let me call Dr. Brian. Hi, Brian. Your take on the presentation.
Oh. Thanks a lot, Elvis, and also thanks a lot, Dr. Yauba, for.
Stop sharing your screen, Dr. Yauba, so we have a. Yeah. Go ahead, sorry.
Yeah, I just wanted to thank Dr. Yauba for such a comprehensive roadmap towards sickle cell elimination in Cameroon. I think Dr. Yauba, the strategies that he outlined today lays a very solid foundation that would lead us to make substantial progress in this journey to get rid of this disease. I really appreciated the emphasis that he made on the importance of strengthening integrated primary healthcare infrastructure and but more importantly, the importance, how important it is to have dedicated departments for nationwide screening and prevention efforts. So I think those were very insightful, really excellent presentation. I learned a lot as well. I think there's also room for us to learn from what other African countries are doing. I saw one of his slide presentation. He talked about that Cameroon is one of the only countries that hasn't really integrated sickle cell disease into their national budget, which I thought was a little bit, so I really hope that the kind of thoughts and strategies he's outlined today will really give us enough room to think. So to think as we think about designing programs and strategies and priorities to redesign this moving forward. So thanks a lot, Elvis. I think it was a very exciting presentation.
Yeah, I agree with you, Brian. You know, when we got this topic, I was expecting that maybe when we talk of elimination, he's going to come with some magic bullet to tell us this is what we're going to do to eliminate sickle cell. But what Dr. Yauba did was reminded us of those basic things that we know that we can do. And he emphasized that if we do them, we can eliminate sickle cell. And you saw that in his presentation, gene therapy was the last of the things he talked about. And he even said, even if this is successful, it's going to take a long time before it becomes, one of the things we can embrace or the tools that we can use. So it was really interesting presentation.
Yeah, the gene therapy thing was very exciting because I think 2 months ago, the FDA here in the US authorized, I think approved CRISPR, which is this new gene therapy. And I would love to hear Dr. Mono's thoughts on this, but the approval of CRISPR technology, and it's quite expensive, but really wanted to hear about, because that's really gene therapy and the innovation with CRISPR and how that can be useful in treating certain genetic disorders. And the accessibility of that, particularly in Africa, where this problem seems to be the most problematic. So that's something I think I would like to hear Dr. Mono's thoughts as well, particularly that area.
Very true. And I was about to yield to Mono to get his take on the presentation. Hi, Mono.
Oh, wow. Thank you. And you can see that this presentation was done by a master class presenter when it comes to translating policy into action. So this was a well policy-driven presentation that shows that we can do things. So I learned a lot too. I've been working with Yauba for the past months. We've known each other for many years, but we've been working actively on sickle cell for the past months, and I've learned a lot from the working group. And I think these suggestions and the papers that are going to come up should be a good guide for the government and for the civil society. And he's one of the advocates who knows how to make things work. So I think we're going to get a good stride in sickle cell that I'm very passionate about. Cancer too, he's working a lot, breast cancer in particular that I'm passionate about in Cameroon, cervical cancer and other things. So thank you, Dr. Yauba. Briefly to Brian's question, it's an exciting time for hematology. And it's an exciting time for genetic medicine in general. I told Brian most of the time, oncology and hematology, we are light years ahead of many specialties. It's sad, but that's true. A lot of people may think it's cardiology, but we are light years ahead. And there are two actually technologies that were approved. There is a CRISPR technology, which is a precise gene editing machine, and there is a lentivirus that was used. So both products, one costs 3 million francs, the other one costs 2.4 million per patient. So the Casgevir is 3 million, if you want to do it, $1 million. And you have the Levocel, which is the lentivirus treatment. We have had more than 20 patients, more than 50 in both groups treated for thalassemia and sickle cell. It's available in the US, it's not even affordable in the US. Yauba said something about knowledge about sickle cell. Even in America, knowledge about sickle cell among doctors was less than 10%. Who even knew how to take care of those patients when they get to the ER? So it's not only a problem in Africa, it's a problem even in New York where I was. And it's a disease which there is intrinsic discrimination. So without saying much, I just wanted to answer Brian's question is, we are excited, but that's not the way to move forward. Even in the US, it's not the right way to go. We last saw the ASH, which is the biggest hematology meeting in the world. That was the main question. Who is going to pay for this? Who can afford this? How many African Americans who have sickle cell, insurance is kicking back, they are being discriminated across. There is discrimination even in the American system in order to even take care of Black patients. Even putting social determinants of health aside, there is that intrinsic discrimination. How would these children even get gene therapy? That's the big question. So we can't even afford it in the US, sadly. So we'll go back. I think we'll talk about this later on. You can't treat the whole world with 3 million per patient. It's going to be catastrophic. So Elvis, let me cut here. I think we have a lot of time for discussion.
Well, you spoiled my mood when you said 2 million, and I thought it was France CFA, and I was like, okay, some people can try, but you changed to plus, and then everything.
$2.5 million and $3 million.
All right. So Yauba was right. We move over to Dr. Kate. Hi, Dr. Kate.
Yeah, thank you so much, Elvis. Thank you so much, Dr. Yauba, for your presentation. So clear, crystal clear, as we usually say in school. So I'm going to open up this forum for Q&A. So as it is our custom, if you've got a question, you can either use the raise hand button on the Zoom, or you can actually type out your question in the chat, and we are going to pick it up from there and direct it to Dr. Yauba. So I think people are warming up. So I think I'm going to start. Dr. Yauba, you talked about screening. Newborn screening is key. And can you just throw more light on the point of care testing you were talking about, that you are working on that test mechanism, and that it's something that can really bring around or bring about a revolution with regards to testing in low and middle income countries like Cameroon?
So can I?
Yes, please.
Okay, I think it's good. I did indicate that I will answer the simple questions and direct the difficult ones to Mona and Elvis. Elvis, do you mind talking about the new point of care test?
Yes, Dr. Yauba, this is a really, really great innovation. It uses just a rapid test, like a test kit, like an HIV test, just with a finger prick and a drop of blood. You are able to actually determine if a patient is AA, AS, SS, and that is just the most basic you need at that point in time to go for further investigation. So it's something that looks as basic as what you can see on the screen. It's just a drop of blood, and in less than 5 or 10 seconds or 30 seconds, you have the results. And so I think it's a very new technology. It's still being, advanced. I don't think that it's been in most of the countries in Africa yet, but I think they are very affordable, and people like Yauba need to promote and see how to get this kind of technology to Cameroon and to other parts of Africa.
Yeah, so there is the hemotype SS and hemotype SC, which are like just specific markers that you can get in order to identify that patients are actually carriers or they are actually having sickle cell. So those trials have been done, they have been very positive. And so this is less than $2. Is going to make a big difference in Africa. So I think so.
Yeah, and I think another good thing about the test is that it can actually tell you the proportion of hemoglobin that the patient is having. So it can actually like inform you on whether the child will need transfusion or not, even at the primary healthcare level. So it's a test that holds a lot of promise. Easy, cheap, easy to use, reliable, sensitive, and so on.
Thank you so much. That was just a warm-up question, and as you can see, hands are coming up. I think that also answers 2 questions in the chat, talking about the cost of the kit and how accurate the test is. So the sensitivity and the specificity, I think that has been answered. And from what I gathered, I think it's something still really new and that it's not yet widely implemented. But if it, okay, Elvis has just said that trials show that it was 100% sensitive. So, yep, so that's it with regards to the data. Okay, I'm going to take Judwin first before I come to Brian because we are in the UK. So positive bias.
Discrimination. Good evening, everybody. That was a really interesting talk. Thanks, JC. So very quickly, I listened through quite keenly.
Judwin, can you introduce yourself? I know you.
Oh, apologies. Yes, apologies. My name's Judwin. I'm a pediatrician. I'm based in the United Kingdom. Yeah. So basically, I think I listened quite keenly, and as a pediatrician, obviously, I've dealt with a lot of patients with sickle cell in the UK, and I think I come from a very different perspective to both yourself, who works in Cameroon, and probably Muno, who works in the US. Sorry. The UK is a tax-funded healthcare system, so healthcare is funded publicly. So the issues around inequality, discriminations are a little bit less. I'm not saying that inexistent, but I'll say they're a little bit better in the sense that sickle cell patients, one of the passports to cutting the queue here, for example, is being a sickle cell patient. The moment you walk up to any ED, it's well established. Like, you say you're a sickle cell patient, you cut the queue, you get seen first. Unless someone obviously is like literally dying. But I think that something didn't quite sit well with me when you spoke about that's to the presenter. Apologies, I don't know your name. You spoke about eliminating sickle cell. And so it sounded like eliminating malaria, which is caused by parasites, or eliminating mosquitoes, which, transmit the vectors that transmit the malaria parasite. And I asked myself I wondered if sickle cell was a life sentence. And I think that's something probably that one of you, the experts at sickle cell, would answer. I think that in terms of primary prevention, I'm not very sure that telling people not to have kids because they're both carriers is the right thing to do for several reasons. I don't know if we are God enough to do that. So first, I think it's important for people to be aware of their sickle cell status more to enable them to make an informed decision. But you have to remember also that the testing in Cameroon is not often accurate. Here in the UK, we see a lot of patients who had faulty results from Africa. And when they come here, they have completely different results. So that's one thing to take into consideration. And secondly, sickle cell is not a death sentence. It's not, patients with sickle cell are not parasites that we can just eliminate. I think the median survival for patients with sickle cell in the UK is almost 70. That's about the same as the rest of the population. So I think what we need to be really hounding on is, one, making people aware. So, at least doing the screening so that people don't get surprised. You have a toddler who's having painful crisis and you don't know what to do with. So hounding on that. And but also improving the care. And I think you mentioned a very good point about being sickle cell being one of the illnesses covered in the universal health service, the system that they're trying to implement. So that's a very good point. But I just think that we should be careful around, it's a very around how much advice we give people around their personal decisions about, getting married or having children and things like that, because sickle cell is no longer a life sentence. And so we need to hound on improving the care of sicklers in Cameroon. And again, Muno, you guys have all mentioned the newer techniques. They're also available in the UK. It's accessible. I think recently made accessible either late last year or early this year, and it's obviously tax funded, so it's free of charge. Obviously, not everybody can afford it, but I'm positive that in the next few years it will be available to children in Cameroon as well. And again, I've just seen a comment pop up that it's like a death sentence in Cameroon. I think Muna would be helpful to tell us what proportion of patients with sickle cell disease have severe crisis, and probably the factors that improve the outcome of sickle cell patients. Thank you.
Thank you so much, Judwin, for some aspects very philosophical and ethical, some aspects, some really direct questions. So over to you, Dr. Yauba. Probably, I know you're going to give the hard ones to Elvis and take the simple questions.
If he tries, I've traveled.
Okay, the next time the person asking the question, if the person doesn't show me the face, I'm not going to answer the question, and I'm not also going to direct the question.
No
to
problem.
Mono.
Just make an exception.
We're going to ignore her. You know, in Cameroon, so I think, Judwin, thank you very much for that very insightful comments and perspective. So I think there are a lot of learnings from what you just described. So first of all, I think we know from the literature that the UK has like the best. That is what they say, the best healthcare system in the world, right? I don't know whether they lost their.
No.
I don't know whether you lost that status after Brexit, but that is what we were told. So with that, and then with also the things that you mentioned, that if you're a sickle cell patient, you actually like skip the queue, actually kind of indicate how advanced and how far you people are when it comes to care and treatment of people suffering from sickle cell. And this actually is not by chance. So perhaps all of the things that you see, particularly surrounding sickle cell care and treatment, why they have to like skip the queue and so on. I think perhaps most of these things have a historical anchor. Perhaps if that was informed by very bad and unpleasant experiences, right? So, and those are the type of things. In short, that is really where we want to get to in Cameroon as well as other sub-Saharan African countries. But believe me, as we stand today, sickle cell, to a larger extent, is a death sentence in Cameroon and many many sub-Saharan African countries, and also some countries in Southeast Asia. It's a death sentence. I think in the slide that I showed, I don't know whether you joined by that time, so 90% of children with sickle cell don't live to see their 5th birthday. So they die before they actually get to the age of 5. 90% of children. So among the 7,000 children that are born with sickle cell in Cameroon, 90% of them would die before their 5th birthday. And before even dying, we cannot quantify the psychological, social, financial traumas or challenges that they have gone through, as well as their families. So it's still a very, very significant and neglected public health problem in Cameroon, not only in Cameroon, but also in other settings. So using the lens of the UK, at least to judge the Cameroon, I think might not really be appropriate. We still have a challenge with sickle cell, and I think even in the US, Mono will say that even the US is still a problem. And then the second point you raised is about the results that are being presented by African by people who travel to the UK from Africa. Most of the times, you realize that the results are not true. And it's really a call for concern for us, at least for me in particular. And perhaps one of the things I can recommend, which I would really be happy to get, is if you can really do some pro bono work, come out with some statistics about the reliability of sickle cell test results from people immigrating from Africa, and then you do that classify by countries, Cameroon. You may not do, you may not want to have like a large sample, but just a small sample. I think that sample, that sort of information can open another debate. Are we using the wrong equipment? Do we have issues with reagents? Are we following the procedures and so on? Right? Because if we miss the diagnosis and then we put a patient on, if we miss the diagnosis, then we can take the wrong medical decision, like putting patient on treatment when they don't need it, or not putting them on treatment when they actually need it, right? So that sort of information can help us. I don't know whether you'll be kind enough to do that. Maybe it can be part of your own passion or your own contribution to the town hall, or to make improve sickle cell care and treatment in Cameroon. But I think since you know it and you have the data, please, we'll be very happy if you can really support us to generate that sort of data. And then it's very interesting to actually learn that people with sickle cell can make it up to about 70 years in the UK. It's very, very impressive. But this is really not what we see in the literature. It's not what we see in the literature. So when you look at the literature, particularly those coming from Africa, you will not even see this type of figures. They die before the age of 5. So I don't know whether whether you have hematologists or oncologists, you do publish information on survival rates in the UK. I think it will be good. And actually, this is really my first time of learning that. I don't excuse myself for being ignorant, for not doing my homework, but all this while I have really grown to know that patients who are with sickle cell disease, if they get the best care, they can go to up to about 30 years. And so if they're females, when they get pregnant, things become very complicated, and their chances of dying during the course of pregnancy is very, very elevated. So I think it's a learning for me. And then you talk about another question about telling people not to have kids. That is not what we said. That's not really what I said. I actually said we should reinforce education, at least having people know their hemoglobin genotype, whether they are AS, whether they are AA, and so on. And then we educate the supporting system, or the a support system that will counsel those people with AS to make informed choices about their partners, their life partners, and also people who if they don't want to get married, or people who they want to get to have a child with. So it's really about making informed the choices about who you want to have a baby with, or who you want to get married to, and so on. And the underlying reason for this is really to minimize the risk of having a child with SS, right? Minimize the risk of having a child with SS. But we understand that it might be challenging, and that is why we said if we are not able to close the tap, not able to close the tap through premarital counseling, having informed decisions about marriages and so on, we could expect a number of children, sickle cell children, entering the pipeline. But if they do, let us also have the systems that could enable us take care of them so that they can reach 70 years. And this means providing them with the necessary vaccines, the necessary nutrition, preventive measures, and so on. But more importantly, providing them with the drugs like hydroxyurea that can actually help to modify the disease. And if need be, in short, where possible, get them to benefit from the new technology that is available. But believe me, it's available in the US. Mono said it's expensive. It's like 2.5 million US dollars or 3 million US dollars. And historically, things will not change. For that technology to reach the developing world, we'll need a medium or an average of about 20 years. Even for COVID, we saw it. There was like global rush, sense of equity, justice, and so on. But the developing world actually received their vaccine a couple of months after the people in the developed world got vaccinated. And this was because of, in short, the time difference was not more than a year because of a number of reasons: political advocacy, and also putting in place systems like the COVAX, African Medicine platform, and so on, that could make these vaccines available to countries in Africa and in developed world. So those things were well calculated, well planned, and so on. But for a disease like sickle cell, it will be very difficult to get those type of platforms and those type of advocacy that could actually make that intervention available for populations in developed countries, unless innovations like I don't know, innovations like artificial intelligence and so on play a role in actually reducing the costs. Because believe me, you bring that sort of treatment in Cameroon, no one will have 2 million US dollars. That's about 1 billion to pay for that sort of intervention. Let me stop here. I maybe pass the mic to Mono and Elvis to see whether they have complementary or additional answers.
Okay,
Thank you so much.
I'll try to be very brief and just hit on some of the important points. My oldest sickle cell patient is 88. Okay, so I want us to know that. Yes, my oldest sickle cell patient is 88 years old. Sickle cell is a very heterogeneous disease, and that's one of the things is not talked about. As Yauba said in his presentation, depending on where they are coming from, the haplotypes behave differently. So there is the Arabic type, there is the Senegalese, there is a Cameroonese. Nobody tests that. There is the Bantu, which is the worst type, and that's what we have in Central Africa. And there is sickle cell C disease, which those patients live longer. There is sickle cell thalassemia alpha measure. There is sickle cell thalassemia beta measure and minor. So if you know that this is a heterogeneous disease, survival is different across the board. Sad thing is that in Cameroon, we have sickle cell Bantu and Cameroonese, which have a very low natural production of hemoglobin F in the first place. So that's the first standard, because when it comes to migration, even into the UK, a lot of Indians migrated. You know, South Indians have sickle cell. A lot of people don't know that. And Brazil, if you look at the data in Brazil right now, sickle cell evolved with malaria. Countries that started eliminating malaria started reducing the burden because the AS did not have any survival advantage anymore. So these countries have slowly gotten into a point. If you really look at all recessive diseases of human trait are supposed to die out. They are not supposed to live. That is why there is no recessive disease as high a burden like sickle cell. There must be a driver. And in the sickle cell situation and all hemoglobinopathies, the driver is malaria. So we are getting to the point where once we eliminate malaria, the Buffy factor, which we have in Africa because of Plasmodium falciparum, is going to lead to a point where AA is going to become a natural advantage over AS. And slowly, sickle cell is going to slowly get wiped out naturally due to just following the Hindy-Weinberg equation. But going back to testing, the reason why there could be a difference in testing in Africa compared to America, the US and UK is because of the testing methods that are used. We use simple hemoglobin electrophoresis, basic. All of you who have been to the lab, you just put that, you put electrodes. But in the UK, they use high performance liquid chromatography, which we still don't even do. In most of our labs, they do genetic testing and high performance chromatography. It makes a lot of a difference. It's very specific. Most patients who have sickle beta thalassemia are not even diagnosed in our setting. Those who have sickle alpha thalassemias are not diagnosed. That's why diagnosis itself could be a problem. The UK has one of the best healthcare systems with its own weaknesses. Very strong weaknesses, but one of the best healthcare. And this, the burden of number of Blacks in the UK with sickle cell, it's small enough to be manageable, despite the high migration from the Caribbeans and Nigerians, but it's enough not to burden the system to a collapse, really. So these patients have historically, the hydroxyurea studies were done in 1988 in Jamaica, UK, US. Do you know when that was done in Africa? 25 years later, published, both of them were published in the New England Journal of Medicine. Africans have not. Sickle cell, do you know survival of sickle cell in Africa is, Nigeria is 18 years, Cameroon is 19, you roam around that. Because burden of survival goes with infant mortality. If 90% of your infants do not even survive, it drags the mortality down. In the UK, all women who are pregnant are tested. All children who are born are tested. They know from the day they are born, they have sickle cell. Pediatricians take good care of them. Same thing in the US. Though we don't have universal healthcare coverage, that's where they think the gap breaks. But these children are known from the beginning. They are initiated on hydroxyurea. We do know that hydroxyurea improves survival, life expectancy, decreased vaso-occlusive crisis, decreases cerebrovascular accident, which is one of the main big things in children, decreases transfusion risk, decreases priapism, improves quality of life of these children, and improves disease markers, inflammation. So survival in the UK is one of the highest in the world. I think it's 67%. US, it depends on where you are, which states. Some states go up to more than even 70 years. Other states like Colorado, but other states which are a bit poor with high burden, like New York City, is about 55. So this tells you sickle cell they can live, but survival in the US and in the UK is not 67 years. It's almost, UK has a good survival of almost 80-something years for both that. So sickle cell still is a major disease that affects survival. And technology-wise, we are not even able to do, there are only 3 bone marrow transplant centers in Africa. I hope you guys know that. There are 3 bone marrow transplant centers in Africa, one in Nigeria, one in Namibia, one in South Africa. You can imagine the technology to use. We do transplant both sickle cell patients, but right now in Africa, we are unable to do allogeneic transplant in most places. It's one of the most difficult transplants because you need to manage these children. This technology has been existing for more than 50 years. Africa has not even succeeded in integrating in most countries. In order to do gene therapy, you need chemotherapy, ablation, and these children are very sick during that period. We are not even yet there. I am still a very big advocate on, I know the word elimination can be a very problematic word in public health, and it comes to become a debate at times if you're acting maybe psychosocial wise, is it the right word to use, or maybe politically right? But this is really, I felt we do eliminate cancers too. We use that word in cancers, but I think if we can inform people who have the AS gene, they know about it, they have an informed consent. We inform patients who are sickle cell, they can get married to AA people. We inform them about the risk. In Africa, a lot of people just don't know. And I think the strategy of informing them early, letting them know, it's going to lead to reduction of even bringing in sickle cell patients that in Africa, they do really suffer. If you've had one in your family, my family has a sick AS trait, and I know a lot of have AS cousins, and you can tell I have sisters who have gotten married and had AS kids, and it jeopardized their marriage. They are not even in Africa, but they got divorced and things like that. It is a catastrophic disease in Africa when it comes to women suffering with these children. Availability, that's why advocacy is needed worldwide. The UK, as Judwin said, has a robust healthcare system, which is helping in these children. But even in the neighboring countries like France, Germany, I see there are other people in the call who I know who can give an insight. But even in the US, And in all African countries, no exception. Ghana, they are trying, but there is still a huge burden coming from this disease. So we need a strategy. And that's where the burden of the disease is actually. Like I said in my presentation, out of Nigeria, the highest concentration of sickle cell patients is in the Bronx, in New York City. Out of Nigeria, it's in the Bronx. We do have the highest concentration of sickle cell patients in the Bronx. So the burden in every country, you can manage it based on what you have. So I would just like to end there. Those were wonderful insights on how a country can succeed, but Africa is really far from there. We need to get into reality of really how things work in Africa. We are far from so many things, and we need to be able to build on that.
Thank you so much, Mona, for that very lateral masterclass on some of the aspects that were raised. So straight over to you. I'm going to take Brian, then Maloba, and Jacob. Quick ones, please.
Yeah, thanks, Dr. Yauba. I know you emphasize a lot on the importance of stakeholder engagement and partnerships. I was just curious, what sorts of partnerships do you think would be the most meaningful, the most impactful in terms of scaling up the screening programs that you talked about? Yeah, and Mono, I just wanted to hear also, just for you, Mono, I know you attended ASH last year, and just curious if there was any discussions in terms of priorities for Africa in terms of sickle cell.
Thank you, Brian. Over to Dr. Yauba.
Okay, thank you very much, Brian. I think in terms of partnership, we need to do perhaps a number of things, and I think as any initiative, we definitely need to have like the leaders that are like spearheading this initiative, and then from there look at the different people who are like or organizations that are likely going to support this endeavor. So in terms of partnership, I think we definitely need a number of people, a number of stakeholders to be on the table for this thing to work. The first is really the government, who is like the main beneficiary. But the problem with the government is that it may not be a priority to them, and that is why we need the civil society. We need the civil society and perhaps families who have been suffering from these sort of conditions. And if you remember well, I think in a country like the US, you have a lot of trust funds that are being set up by people in memory of some of their victims, like people who died from cancer or from other conditions, at least just to promote some research and development of molecules, or just to like galvanize advocacy or other things. So we need those type of things. So civil society is critical. And then within the civil society, I think we need that patient groups, particularly those who are like suffering from the disease, or the families are suffering from the disease. And it's very important, particularly the patient group, because if you look at the history of HIV, what actually like led to even the development of antiretrovirals was movement from the patient groups, particularly from the US. So we need those type of models. And now after that, we need other things like other stakeholders, like funders, people who can fund initiatives to control sickle cell, philanthropic organizations, and also children organizations, and organizations that are also focused on the rights and health and welfare of women. And more importantly, we will definitely need the farmer, because the farmer produces the drug, so the molecules will have to come from them. But you need some people to actually get the farmers to act, and that is why we will need that patient groups, because it's much more easier for farmers to act if we have like a very strong movement from civil society and patient groups that will cause politicians to maybe allocate the necessary resources or to engage donor organizations to set aside funding to procure medications that will be produced by farmers. So those stakeholders are also important. And then if we think about the broader picture, I think we can extend, although bringing in institutions like religious institutions and also traditional institutions and so on. So if we have like a well-structured religious institution like the Catholic faith, where they have like a line of command where anything that the Pope says is implemented. So if we can really get the Pope to like tell all the bishops or the reverend fathers that place when officiating marriages, ensure that people, ensure the couples are screened, they know their status. So those type of things can actually really, really help. And then again, which other stakeholders are important? Talk about even things like development banks, right? So development banks, you only need to show the impact of the economic impact of sickle cell on an economy or on a society. Yeah, it can be direct, it can be indirect, it can be loss of, it can be dailies, it can be qualis, and so on. And then you transform that into monetary terms, and then you show them, then they will see the reason why they need to invest, why they need to support governments, maybe through loans or through grants to address this type of problems, to build the necessary infrastructure, be it a policy framework or screening programs, and even to have money to procure and distribute the commodities that will be needed to improve this program. So all of those stakeholders, they will absolutely be necessary and needed for this sort of control or elimination program to work. Over.
Okay, thank you, Yauba. I would answer the second question. I'll try to be brief, then I'll answer one question from Dr. Gobina on the chat. So ASH, actually all of Europe is benefiting from what the US decided in 2017 to do about sickle cell. So sickle cell became a priority on ASH because it's an orphan disease, which is the most prevalent genetic transmitted disease in the world. But we had treatment for cystic fibrosis about 5 to 10. There was just one for sickle cell, which was discovered by coincidence, called hydroxyurea, for many years. So ASH made sickle cell a priority. The NIH has been sponsoring sickle cell trials for free, like we did in the US, sponsored HIV trials, and they were sold in Europe cheaper. And were sold free in Australia. These are things the taxpayer money does in the US, and this becomes a big political fight. So in sickle cell, we have sponsored crizanlizumab, which is approved in the US and in Europe. We have sponsored voxelotor. We have sponsored L-glutamine. We have about 5 to 10 drugs which are still in the pipelines, which are being sponsored by taxpayer money in order to try to help sickle cell patients get drugs that can be approved. And so sickle cell has become, it's a priority for ASH, but it becomes difficult for pharma companies after getting these drugs to prioritize Africa. So this is a discussion, an ongoing discussion, and I always advocate for those who find themselves in international organizations. I always talk about Africa when I'm there. So when I raise my hands, they know that this guy is going to talk about something very controversial and maybe very thought-provoking, especially because I asked them, 3 million, 2.5 million, who's going to pay it? How are we going to cover it? If we cannot cover simple bone marrow transplant for African children, we know the problem with bone marrow transplant in Africa is that we have the highest heterogeneous gene in the world, Africans. Caucasians' genes are very close to each other, so getting a match is easy. Getting a match for Africans is difficult. That's a topic for another day. So that is where there's a big problem even transplanting Africans and even transplanting sickle cell. That's why the NIH, Johns Hopkins, Black universities are working a lot on trying to do haplotransplant, cord transplant from, those are all things that we're using. And transplant, just to make Francoise get happy a little bit, Francoise is very interested in transplant, but it has become safer in adults. Recent technology, knowledge from the NIH shows that We have regimens that we can easily transplant Black sickle cell patients who are even above in their adulthood because children survive better. So there is a lot going on ASH concerning sickle cell. Now going to answer the question, how is malaria related to sickle cell? It's a very interesting question. So I'll bring it very simply. If you look at human evolution, the sickle cell gene, which is in the beta chromosome in position 6, is a very fragile gene. It has mutated multiple times in humans. It's not the first time it mutated, and there are proofs for that because when you study genes around it, there are haplogenes that you study around it, so even Caucasians do have that mutation occur. Everyone in billions of years for human evolution, that mutation kept happening. That's why you have the Cameroonese, the Senegalese, all of that is because we have studied genes around it. But why did sickle cell not affect Caucasians? Because it's a recessive gene. In the Hindy-Weinberg equation, when you do genetics, all recessive genes they die out. If they don't die out, there is an environmental factor that is keeping them staying and surviving. So in the case of sickle cell, what happened was that once that mutation occurred in Africa, falciparum was the driving force. Those who were AA, children who were AA back in Africa in the days, that's why your parents used to say for a child to survive was a miracle. They all died from malaria because falciparum loves pure blood, AA blood. Those who were SS, they all died from sickle cell. Falciparum too doesn't love sickle cell blood. And those who were AS, they were the advantaged children. So they survived, they had less malaria. So if you eliminate malaria in Africa, then the AA starts having an advantage equal to the AS, same advantage, and over 1 million years, the genetic pool is going to change. The advantage that AA was carrying is going to get lower. And the AA gene is not going to be an advantageous gene in West and Central Africa. So that's really what happened. So as we're eliminating malaria, you see that proof in Brazil, you see it in other countries who had sickle cell. The numbers are dropping. It's just that you're getting more pool of AA circulating than naturally they would have done with malaria being present. So that is really the explanation. But we have so much AA that this is going to take 1 million years. That's why you need to screen people, let them know their status. You're not going to tell them how to get married, but at least they know. And they are able to test these children early and let these children know so that they don't get married to another sickle cell or another carrier and get children, and leads to traumatizing adulthood for them. Even for the children who are suffering, even the best sickle cell patients end up in the hospital with everything being done. Even those who survive up to 82, my patient I'm telling you about, she's still in the hospital for pain crisis. So her quality of life, there is a difference between quality and quantity of life. Her quality of life is not as good. You can ask any Black child who goes to the ER all the time. Quality of life is a big thing. Just the psychological aspect of not missing school, not being able to pursue certain professions that you want to, not being able to do certain athletic things that you want to. So it's a big thing. I always look at not quantity, but there's also quality of life, which is a big part. I know this can be a huge debate going forward, but that's the tip of the iceberg about discussing sickle cell pathogenicity, because it's a complex topic. And we are happy to have Professor Wankam, who has done a lot of research on that, but we may bring him to the town hall someday. Thank you.
Great.
Thank you so much, Mona.
Wrapping up.
Yes, so we would be wrap it up within the next 7 minutes. So I was privileged enough to watch the last NIH video cast on sickle cell. That was 2 weeks ago. And Professor Wankam was actually doing a presentation. It was actually a masterclass. And he did talk about the evolution of sickle cell from Africa to the rest of the world. I think it's still on the internet, something interesting for people to see. Maluba, if you can go straight to the point, that would be great.
Yeah, thank you. Very interesting discussion. And thank you, the town hall, for bringing us together, especially for me to meet people like Professor Njunda. Anna, who was my former teacher in University of Boya. Yeah, I'm Franklin Maloba, calling from USA, microbiologist, immunologist background. Yeah. So my question is, as Dr. Mona mentioned, that actually sickle cell is due to some sort of epigenetic changes, which is caused by the presence of malaria. I wish to know if these changes could also affect those that are AA, for them to have children that could be carrier and suffer of sickle cell anemia. Because there's a case where I know that the mother of the child is AA, but the child tends to be a sickler. How is that possible? Yeah, and then talking with the bone marrow transplant, I don't know if the bone marrow transplant actually affect the niche, which will affect the hematopoietic stem cells to always produce blood cells that maybe this glutamic acid is not being replaced by valine. Is that the case, or is this just the cells that continuously produce without actually affecting the niche, which will lead to the production of these cells? Yeah, thank you.
Maloba, I'll just be brief. So the first question is a very interesting one. Yes, you can have a mother who is AA, but the father needs to be AS for that child to be a sickler. What happens here is that they have not tested. There must be an alpha thalassemia gene that is not tested and a beta thal. So we call those patients sickle beta thal, measure sickle beta thal minor, sickle alpha thal measure, sickle alpha thal minor. And that's why the child is sickling. And that's what is really happening. You just need to do, if that's the real father, there must be someone with sickle cell. As you said, in genetics, sickle cell is a fragile area that I said already in the gene. So when it mutates, there's one amino acid. What happens here is that there is an acidic amino acid which is replaced with a known hydrophobic amino acid. It's just complete replacement. When that amino acid is replaced by a basic amino acid, you can get other diseases. So let me tell you the different diseases that exist, which we study in hematology. At times they are rare. You have sickle C. You have, hemoglobin C disease, hemoglobin E disease, hemoglobin Silver Springs, hemoglobin Banju. There are many diseases of hemoglobinopathies. In my boards in hematology in the US, it's said mostly by pediatricians. They are very mean. They love diseases that no one has. But I'm just telling you that this is more complex than you may want, that meets the eye. But SS is when you see it's easy. But if your father is AS and you get married to an AA who has a beta thalassemia minor gene and you get the beta thalassemia minor, you're going to sickle. But your disease is not going to be as bad as someone who has SS disease. Then your disease can be worse with retinopathies and other seizures and also cerebrovascular accidents if you have beta thalassemia minor S disease. They are sickest. And there are people with beta who have SC disease. It's very common in West Africa because hemoglobin C disease is not very common in Central Africa. It's common in Senegal. It's common in, that's why sickle patients that you see at times in Senegal, in Mali, in Ghana, they are less severe than our patients just because of haplotypes and also because of the common SC trait that is circulating. So that's really, it's a debate we can, it's a discussion, it's scientific, it's a discussion I love because it's a discussion we can have, and even many hematologists in the US don't know this information. Sickle cell, not all sickle cell patients are the same. Not all patients who carry the gene, even the Bantu gene is notorious for not producing zero hemoglobin F because of where the mutation took place. If you look at the treatments that we are doing right now,
we have 1 minute more to close the session.
Yes, the genetic testing that we do now, you have genetic testing that was done in the area which is called BCL2A. That's what promotes alpha fetoprotein. And there's also genetic editing that was done in the BAT87 cure gene. So those are the areas that you can do genetic. And Dr. Wankam is so good at that. I think he's a Cameroonian that I'm proud of. He has so much research into the future of what can be done for sickle cell in Africa and why all sickle cells are not the same. Thank you, Elvis.
Great.
Stop listening. Yep. Maloba, thank you for that question. I was just like, when you were asking, why are you scratching Mono this evening? Because I know that would take us into some.
But I think many doctors don't know about that in Cameroon. It's something that they really need to tell the doctors because it was a really challenge in the hospital. Yeah.
All right. Thank you so much, Maloba. And, you know, just a story. When I was growing up, talking about the importance of testing.